So welcome everybody. This is an event that we've sponsored. This is from the Bander Center for Medical Business Ethics. So the Bander Center is an ethics center that's housed in the School of Medicine at St. Louis University that focuses on education and research about issues in medical business ethics. It was established in 2007 based on a grant from the BF Charitable Foundation. I'm Jason Kuhn, the Executive Director of the center, and we couldn't be more thrilled to be here at the Conference on Medicine and Religion. So, we have an educational mission, a scholarly arm, and we put on events like this one. In fact, we put on 4 other events this academic year. I encourage you to go look us up on YouTube and take a look at the other events that we've had that are similarly structured. My highest hope is that someone today here will get a spark from something that was said, or meet someone compelling to collaborate with, start a project, change the world for the better. So my guest today is Patrick McCruden, who just started as the Chief Mission Integration Officer for SSM Health, which is a Catholic, non-for-profit, United States healthcare system with more than 1,600 employed physicians and 33,000 other employees in 4 states, including Wisconsin, Oklahoma, Illinois, and Missouri. We are here to talk about the future of Catholic healthcare in what is our final signature event of the 2017 to 2018 year. Patrick McCruden serves as Chief Mission Integration Officer for SSM Health. They have care, in his role, Patrick leads the strategic integration of SSM Health's mission, values, vision, and Catholic identity into all aspects of the organization, from culture and structure to policies, programs, and practices. He leads the development and implementation of a full continuum of activities designed to spiritually, ethically, and culturally enrich SSM Health employees and physicians. Patrick has been part of Catholic healthcare for over 30 years. Patrick's initial work in healthcare was in pastoral care. He's a certified chaplain and worked for 15 years, primarily as a chaplain and director of pastoral care, before moving into the mission integration and bioethics field. For the last 20 years, he has worked for health systems in Iowa, Arkansas, and Missouri. He developed the first hospital-based children's advocacy center in the state of Arkansas and serves as its board chair. He also serves on numerous local and regional boards of directors and serves nationally on the Theologian and Ethicist Advisory Council for the Catholic Health Association. In addition to his work with SSM, he serves as Adjunct Assistant Professor of Medical Education at Stritch School of Medicine, Loyola University, Chicago, where he teaches in the Bioethics program. A native of New York, Patrick received his undergraduate education at New York University and the University of St. Thomas in St. Paul, Minnesota. He continued his graduate education at Catholic Theological Union in the South Side of Chicago and trained as a hospital chaplain at the University of Chicago Hospitals and Clinics. He received his bioethics education at Loyola University, Chicago, and additionally, he is a permanent deacon in the Catholic Church. So Patrick McCruden, welcome.
Wow, thank you. What an introduction, appreciate that.
So let's hit it right off the bat, Patrick. Okay. So as you know, I guess, Amazon, Berkshire Hathaway, JP Morgan Chase have announced that they plan to start a healthcare company, okay? We were in the dark about the details. They just made this kind of blanket announcement, and we were in the dark about the details until Jamie Dimon, the CEO of JP Morgan Chase, included some details in his letter to shareholders that recently came out. And he says, the company would focus on using big data, virtual technology, better customer engagement, and more consumer choice to address critical problems and issues. So they're specialists in that stuff. I mean, with disruptors like this out there, does Catholic healthcare even have a role, a future? What's that like, this setting?
Well, the short answer is yes. I don't want to say the short answer is yes. A little bit of context, I think. When we think about healthcare, up until pretty recently, it was very local, hyper-local. So, if you're going to visit your doctor, you're going to go to the doctor in your neighborhood, your local hospital. When you wake up with chest pain or an appendicitis and you need to see a surgeon or something like that, you're going to go and stay local. And so health systems have grown up, and SSM is just like that. We're providing everything kind of from soup to nuts. So, we've got maybe even pre-hospital care, we've got primary care, secondary care, tertiary care, home health. We've even got a insurance company up in Wisconsin. So we have all of that, and that integrated health system is terrific. But employers don't see the integrated health system as being so terrific because often what happens is they're confused by the differences in quality and the differences in price that they're going to encounter around the country. So these large employers are wanting to do something about it. So when I hear that, we're not exactly sure what Amazon and what J.P. Morgan are going to do, but when I hear that little phrase that you talked about there, so big data, one of the things that they want to do is do analyses of results so that they can segment the healthcare market and bring certain segments to places which have the best outcomes. So, for example, would be Walmart, right? So Walmart is already doing this around spine surgery. So Walmart got upset because they say, we're all over the country, people hurt their backs all over the country, they go to their local doctors, they go to their local hospitals, and we have these widely divergent outcomes for our employees. So we want to do something about that. So they looked at the data, or they had a company that they hired who looked at the data, and that company did analysis, and then Walmart now has said, well, we're going to send people to 3 or 4 centers of excellence if they have spinal problems. And the way they get their employees to do that is they say, you can go anywhere you want, but if you go to this place, we're going to pay your airfare, we're going to put you and your family in a hotel, you're going to see this physician, and you're not going to have any co-pays, you're not going to have any out-of-pocket expenses. And what Walmart found when they did that was they did about 30% less spinal surgery, and the people who did have spinal surgery had better outcomes because they were going to so-called centers of excellence. So that's an example of how they're using big data to impact patient choice and to impact outcomes. The virtual space is another case of, we talk about it as segmenting. So the virtual space is segmenting. You don't have to go to your local physician, even your local urgent care, because you can do it virtually. So that's another way that they can keep costs down by having somebody at a virtual care center see their employees. Perhaps they'll set up something even within one of their employer sites, one of their places of employment, where people can see the physician. They don't even have to leave work. They can see the physician virtually and work from there. So that, I would say, not shame on Catholic healthcare or shame on big healthcare, but they are responding to concerns that businesses have held and that patients have held in wanting to increase patient choices. So I think that's the space that they're in. That's the segments of the market that they're in. Where does Catholic healthcare fit into that? So the flip side of that is we are in the community. So we're hyper-local in the community. We want to care for all segments of the community. So it's not just the people who are employed by a certain employer who is able to make these opportunities available. We're taking care of the rich, we're taking care of the poor, we're taking care of the insured, the uninsured. So there's that whole aspect of Catholic healthcare, taking care of everybody. And then I think it's the growing emphasis on population health, being embedded in the community, and working with community programs to address health needs, health disparities, the things that are happening in the community.
Yeah, so there's something about, finding efficiencies, right? When you're talking about big data and big companies and so on and so forth. And these companies, they specialize in that. That's almost the whole thing right there, is finding efficiencies. And, Do you think this like caring attitude, this like we take care of everybody, is going to be able to find the same efficiencies, or maybe not? And if so, what's going to balance that?
Yeah, it's a great question. I think we can find some efficiencies, so we can try to get into some of that same space. We talk about it, and you've seen probably even locally. So SSM is in Walgreens. We were just talking with some folks. Mercy is in with some other group that's doing urgent care. So you can get into that virtual care space. It's a little different than what has been traditionally what we've done, but it is a way to get into it. But the other possibility is that might be a space that we say someone else is doing that and doing it well, and we're going to let them have that segment of the population, and we're going to try to do as much as we can for our segments of the population. There's never been a shortage of people who want to take care of paying customers. So we've seen this segmentation before, and I don't want to set it up as a good and evil type of thing. So specialty hospitals, that was another segmentation. So you had specialty hospitals that opened, and they said we're going to focus on orthopedics, we're going to focus on heart, we're going to have better outcomes, we're going to have a better patient experience. It's very difficult to argue with that when you're a patient, but then the patients who have multiple comorbidities, the patients who are uninsured, the patients who are going to be a problem, they want to bring to the St. Louis University Hospital or St. Mary's Hospital or the local not-for-profit hospital. Yeah. So that's the challenge.
Great. Welcome to the future.
Yes.
Of Catholic healthcare, I guess. Yeah, that's great. I'm curious about another thing. So, Pope Francis, I think, has been the Pope for like 5 years, right? Something like that. Has that been 5 years already? Is it longer than
Longer?
That?
Yeah.
6 years, maybe. He's promoted a church that is poor and for the poor, right? He said things like this, I prefer a church which is bruised, hurting, and dirty because it has been out on the streets, rather than a church which is unhealthy from being confined and from clinging to its own security. More than by fear of going astray, my hope is that we will be moved by the fear of remaining shut up within structures which give us a false sense of security, within rules that make us harsh judges, within habits which make us feel safe, while at our door people are starving. And stuff like these. None of us can think we are exempt from the concern for the poor and for social justice. So this dovetails with the mission of Catholic healthcare in some way. Do you think Pope Francis empowers Catholic healthcare?
Absolutely. I think empowers and challenges us to really go back to our roots. I think in some cases, hospitals, Catholic hospitals included, have kind of hung the hat of their mission on charity care, on the people who come to us and receive charity care, which is important, and it's always going to be important because people are going to need that care. But we know that medical care adds up to about 10% of what contributes to longevity, to health. I mean, we know about all the other aspects of what adds up to health, right? Your genetic makeup, your habits, your built environment. The old, your zip code is going to say more about your health than your genetic code, right? So we know all of that, and what are we doing to respond to that? How are we getting out into the communities with the smell of the sheep, if you will, as Pope Francis has challenged us to do that? And I think it's in our DNA. In fact, I'm wearing a button that it looks like a basket that the Franciscan Sisters of Mary gave me when they missioned me a couple of weeks back, and it's representative of the foundress of SSM, Sister Mary Odelia Berger, who just a few blocks from here, I'm not sure exactly where, they lived at St. Mary of Victory's church. And the sisters would go out, and sister would have the basket, and some people would have a little money and put money in the basket, and some people wouldn't have any money or bread or whatever, and they would take out of the basket. So that's in our DNA. The sisters who were the pioneers who started these ministries, they didn't start them to start hospitals. They started them to respond to the needs of the community, and then hospitals became a way to do that. But we really need to get out into the community, partner with the community. I think that is a way for us to start addressing those determinants of health, social determinants of health. And it's another way, it's another space that we're not going to find Amazon, that we're not going to find other entrepreneurs wanting to enter. They're probably not going to enter that space. So it's a space that's going to work long into the future.
Yeah, interesting. I think maybe phrase it a slightly different way. Maybe before Pope Francis, there wasn't as much of a concern, right? It's much more prominent in Francis, this like concern about the poor. It seems to me.
Yeah.
Do you think, I mean, does Francis come up in Catholic health? I mean, for you, is this new emphasis on the poor something that's kind of driving to the mission?
I think Pope Francis does come up because of our connection to the wider church, and that emphasis of the wider church certainly comes up for me and for SSM because we have those Franciscan roots. Now, Pope Francis isn't a Franciscan, he's a Jesuit, but he took the name of Francis purposefully to call attention to that. So I think that return to taking care of the poor is something, preferential option for the poor. And that's, again, that is, when we think about addressing the social determinants of health, that is another way that we can practice that preferential option for the poor. Certainly we practice it when we provide charity care and provide the best possible care with surgeons like you taking care of folks whether they can pay or not. But another way is to be out there in the community and addressing those social determinants. I mean, and so I say this, not patting myself on the back, but just out of, it was a coincidence. So this afternoon I was out in Ferguson meeting with two pastors, and we're looking at revitalizing a neighborhood there, taking a shopping center that had a Schnucks and several other things, and it's been empty for 15 years. And there's a community group that's working to revitalize that, put an early childhood care center into it, get a bank in there, and they need medical care. So that would be, a perfect way for SSM, Catholic Healthcare, to partner with the community and say, we're going to help revitalize this community. Very different than, being in the emergency room and taking care of somebody who comes there.
Yeah, yeah. You brought it up. I'm a surgeon. Yes. I work for Catholic Health. So, one thing the Bander Center likes to do is try to see if we can see whether there's some kind of a dilemma for the individual physician at work, at the bedside. Contextualize it in these big, broad, global issues like the one we're talking about. Yeah. But, so I thought of one. So it's kind of a weird problem you all have put me in as an employee of SLU Hospital, is that, I'm a general surgeon. I'm not that much of a specialist, but there are a couple of things that I do that are relatively unique in town. And there may be, 4 or 5 people in St. Louis who do this, the same way, that kind of, are able to treat this kind of condition. I'm just going to leave it abstract here so we don't get into the weeds about what it is. But, but the problem is that since I work for Catholic Healthcare, sometimes I'm the only one in a patient's life who's able to operate on them or give them an opinion because this person can't go to the other surgeons. They don't take his insurance, The problem arises, normally like that's okay, but the problem arises when a second opinion is necessary, or this patient somehow finds me, not to their liking, right? So what do we do? I am good, but I'm not perfect, so there's got to be the need for a second opinion sometimes. Do you think Catholic Health should have a fund to alleviate problems like this for me? It does weigh.
Probably not.
Have you ever heard of that problem? I mean, is that something, have you ever heard of that?
No, I mean, so again, I think it's, is this the Medicaid population?
Medicaid, Gateway for Better Health is an insurance product that's federally funded for the city of St. Louis.
Okay,
And, patient pay, no money, no insurance.
Sure,
This happens, this patient comes in.
Yeah, I mean, so again, it kind of comes back, it's almost back to that first question about segmenting of the market. So you're always going to have folks who are willing to take care of patients who are well insured. And then you're going to have fewer folks who are willing to take care of patients who are either uninsured, underinsured, or poorly insured. So that's why my initial response was probably not, because I think through Catholic Healthcare, we're supporting having an excellent surgeon available to provide this service. I mean, I'd be interested in what other people think about it. Also, of course, I came from here, I was in Arkansas. This sounds more like a big city problem, because in Arkansas, you'd be really lucky if you had one good surgeon who could do this kind of specialty thing. So it sounds like more of a big city problem, but maybe there's some other smart people here who would think, but it probably wouldn't be, because it would kind of feel like we're making sure that we have this service available by having yourself and other 3 or 4 surgeons who do it. Then we wouldn't want to develop a fund to pay people to go somewhere else to have it done.
Right.
Well, what do you think?
Yeah, good question. I don't know what the solution is. I mean, it's kind of the patient's sitting there saying, I really want to see, it doesn't happen that often, but, I really want to see someone else. And I'm like, well, let me refer you to, oh, wait, he doesn't take your insurance. So it happens. It's a ethical dilemma that you don't expect when you're setting the system up like this, I mean, we're going to have a little Q&A at the end if anybody has an idea about that. I'm all ears.
Yeah, I would definitely like to.
One thing that I'm particularly keen on myself that is something that you're interested in, that is in the 21st century, is that physicians are so diverse, right? Physicians themselves are diverse. You can walk down the hall in the School of Medicine at St. Louis University, and they have every class from 1930 or 40 or something like that, and you can just progress down the diversity row here. You know what I mean? And so they were white males, then, and now it's, a very diverse class, right? So we're in this system where the physicians that are practicing for Catholic healthcare are so diverse also, not only in their racial and ethnic identity, but in their religious beliefs, and maybe even, believe it or not, in their moral beliefs. Is that possible? How should Catholic healthcare bring together all these actors? And when we met, you talked about Charles Taylor and this concept of unity and diversity and things like that. If you could bring that into your response, because you did it so eloquently at our meeting. So
maybe there was wine at the
meeting.
Well, I know, probably more eloquent. Yeah. Yeah, it's a topic I got interested in about a decade ago. Well, back up. Folks probably know that many physicians now are becoming integrated into health systems. We say integrated because physicians don't like to be called employees. So many physicians, and so probably about a decade ago when this was really taking off, it took off in the 80s, and then it went through a cycle where it went away, and about a decade ago it started up again, where physicians were being employed by health systems. I'm not sure the exact number. I think 65 to 70% of physicians now are employed by health systems. you know, and in some specialties, yeah, even higher than that. So in my role in Catholic healthcare, when we would have these large physician groups coming in, I mean, technically, they were a part of Catholic healthcare, and then I started asking myself, well, what does it mean for a physician to be a part of Catholic healthcare, other than a few prohibitions? You know, I mean, I think everybody would say, well, we know there's certain things they're not going to do. And so that's kind of how I got interested in it. And again, I was in Arkansas, and one of the things about, as you were just saying, Jason, was in Arkansas, actually, our physician population was our most diverse population. Many foreign medical graduates, things like that.
More diverse by far
diverse
than the surrounding population.
Yeah, than the surrounding population. And so I got to thinking about it, and in terms of integrating them into Catholic healthcare, it didn't strike me that it was going to work the way that we have typically done with other leaders, which is try to form them in the exact same way that we had formed religious leaders in the past. So I took more of and you mentioned Charles Taylor, more of an approach of unity across differences rather than unity through identity. So instead of trying to make everybody kind of act and think alike, try to find the commonalities and build formation around those commonalities. Things like compassion, forgiveness, virtue, the common good. And you know, I think we find the philosophical, theological roots for that in natural law theory. So those were...
That's interesting. I mean, those sound, you know, just challenging a little bit, like secular moral goods. You know?
Yeah.
So that's maybe the strategy. That's the strategy to find that unity. Is to, I mean, do you kind of abstract the moral goods and don't call it God, you don't call it religious? Is that kind of the thing, or is there some other way?
Yeah, no, so, yeah, and I should clarify, I mean, we're unashamedly Catholic and confess that and profess it, but when we're trying to integrate anybody, really, but integrate these large physician clinics, oftentimes what we find is it's more practical, if you will, and it's more efficacious. Yeah. So we're Aristotelian, begin with the end in mind, to start with things that we can agree on rather than why we agree about them. So we can agree on vocation. We can agree on how we treat one another, how we treat patients, compassion, forgiveness, virtue. You know, for the bioethicists in the room, that's kind of part of the founding myth, right, of bioethics, the Belmont Report. When the commissioners got together and were coming up with the principles for the Belmont Report, they found that they could agree on what they should do. They could agree on the norms. They got into the disagreement when they were trying to figure out, why do we agree?
Why is that? Yeah, maybe they just stop, you know.
Yeah.
You kind of just stop asking why we agree,
yeah.
right? I mean, it's good enough, right? Or something like that.
I think also, well, there's much stronger philosophers out there than I, but I mean, being Rawls, overlapping consensus, that would be another philosophical root of this. And then Charles Taylor, unity across differences, where you know that speaks to multiculturalism. So Charles Taylor, for those who don't know him, he's a Canadian philosopher, and he's speaking around multiculturalism, and they're using a lot of his thought in Europe as well, where there's multiculturalism.
Yeah, great. What about so you're a nonprofit, right?
Yeah.
Catholic healthcare is a nonprofit arrangement, right? And so no margin, no mission is a common thing to say in nonprofit, right? I remember the first time I heard that, I was like, that makes sense, you know? You got to make some kind of money in order to like keep it going, keep the lights on. And so does this hold true for you? Or is there something else? So I'm thinking that when you open your doors to the poor, right? and those like without the ability to pay or without the ability to pay well, you know, which is a lot of the patient population, your margin can become very thin, you know, and can even disappear, maybe turn negative, you know. So that is if you don't have a set of paying patients to offset that, right? But there might be also a conceptualization out there that doctors that treat the poor are like inferior doctors instead of big-hearted ones. I got to go to the ACGME in Chicago, right? And I remember, and this is when I worked in Catholic healthcare, treating the poor and so on and so forth. And it was a course about assessing residents, okay? And, you know, it was totally unrelated to any of this stuff, you know what I mean? But it was like, the guy said, you know, we were talking about entrustability of physicians, you know, people that kind of graduated at the bottom of their residency class. And the guy said, you know what people do who graduate from the bottom of their class? They treat the poor. And I almost was like, I didn't quite check, because it wasn't part of what we were discussing. But, you know, that happened to me. And I'm thinking that that's a view that's out there by this person, you know, and if he has that view, I think probably a lot of other people do. So, you know, do you think Catholic healthcare can maintain this kind of in the current era? I mean, what's the deal there? How do you kind of...
Wow, there's a lot there.
That was a lot of stuff. Yeah, so in the contemporary era, when you treat poor patients, people might think, I mean, low-income patients, people might think you're an inferior doctor, but you need to capture that profitable market segment.
Sure, yeah, I mean, so a few thoughts. That was Sister Irene Krauss who made that no margin, no mission. She was the first CEO of the Daughters of Charity health system. I think she's sorry she ever said it. She's gone to her eternal reward now. So, but and when she was talking about that, so when she was talking about that, her purpose was to talk about the efficiencies that need to be gained in the system. And good business practices. And so we need to have, obviously, efficiencies, good business practices, but she never considered it in terms of, you know, how we're going to choose the populations that we serve. But, I mean, to your point, it is true, and coming from Arkansas, it was a great reality in that it's the lowest Medicare reimbursement in the country, very low. We did have an expanded Medicaid under the Affordable Care Act, so that was very helpful. But a very small commercial patient population, so it's a very difficult place to stay open, any health care, but especially if you're going to serve the poor. And so you have to be ultra efficient in a situation like that. So I think as we serve more and more of the poor, as these interrupters, as these other groups come in and take more of the better paying business, it's going to be incumbent on us to be more and more efficient and in order to fulfill our mission.
Yeah.
I've never really heard it that way. I've never had that experience that people who serve the poor, physicians who serve the poor are of a lower quality. We've struggled with the business decision, and now we're getting a little bit into the weeds, but, you know, payment mechanisms for physicians. If you do it on a bottom line compensation model, then you're incentivizing physicians to take care of poor people. So I find bottom line compensation models somewhat unethical. Instead, it should be an RVU type model, so that if you're doing a surgery on a patient without insurance, or a patient with Medicare, or a patient with the best insurance in town, you're getting paid for that. You're getting paid that RVU.
Right. What you're saying is an RVU is an RVU is an RVU,
right.
But I might get paid a different amount based on an RVU from, you know, a wealthy patient versus a poor patient. That's what you're talking. The bottom line model means like the dollar amount that's coming in. Right?
Yeah, but on the RVU model, we guarantee the RVU.
Right.
Yeah. So it kind of comes to the health system. So that's one of the power. That's one of the great things. That's the power of having a multi-state and even a national health system, because you're always going to have facilities that are going to struggle because of patient population, and that's part of the role of the health system, is to uphold that and say, you know, you're either going to make a smaller profit, and we're going to uphold you, and we're going to give you the capital that you need in order to fulfill your mission. You know, and
right.
that's the power.
That's what's done. Yeah.
It's a little bit of Robin Hood. You know, I mean, that's first of all, that's what Catholic healthcare does. That's what you know, I have my pen here. You know, like I said, the sisters would go out, and some people would put in money, and some people would take out money. Well, in a certain sense, that's what Catholic healthcare does, because we're providing care to everybody. The people who can pay have better insurance. We operate efficiently so that we can take care of the people who can't pay or have less good insurance.
Great. That was fantastic. Thank you. I wonder if we can open this up to audience participation. We have done this on every single signature event that we've had. We've had some great questions. We want it to be a dialogue, so after you've asked your question, please respond. You know, again, we're going to have kind of a little bit of back and forth, so I wonder if anybody has anything they'd like. Let's start off with Dr. Jeff Bishop. Thank you.
Hmm.
With segmentation, it seems that what's happening is money that would have come in is now not coming in. And so if that's the case, then can you really continue to serve the poor? Because you know, no one's walking around with a healthcare basket, saying, please put money in, because that it's just no one has that kind of money.
Yeah.
So you have to take it where you can get it, where things that happen in the market. So with the segmentation, it seems like this is a potentially very bad thing if some of your local, using your example, Walmart patients who would have gone to SSM, let's say, are now being flown somewhere else, and then no one's putting it in the basket. So how do you see survival as a possibility if we have these little segmented populations?
Yeah, it's a great question. So a couple of ways. One, you can, if you specialize in an area, you try to capture that segment. So you say, yes, we want to get into that line of work, and we want to try to capture that so that we have the ability to continue our mission. That's one way to do it. The other way is to go into areas that, as I was saying, those operators aren't interested in going into. So risk-type approaches for the Medicaid population, the Medicare population, ACOs, accountable care organizations. So where you're saying we're going to take the efficiency of the integrated system, where you have everything from soup to nuts, and we're going to take care of these patients for a set piece of money, right? And then you're at risk for that, because if you can't take care of them for that, then you lose money. If you can take care of them for less than that, then you make a little bit of money, and you lend that to the or use that to take care of the poor. But it's something that we're thinking about. I mean, all the time when we strategize, we think about these are the people coming into the markets, and do we want to partner with them or not? I mean, because it's dangerous either way. It can be dangerous to partner because they're going to want to partner on price. So you know that what's going to happen. I don't know, do we have time for like an example?
Go for it.
Okay,
yeah,
so like an example, a coworker said she had a problem with her foot, and she thought she needed to see a podiatrist, and so she needed to see it next week, so it had to be pretty quick. So of course, being a good coworker, she went to the SSM website and tried to find somebody, and she didn't see any pictures next to a lot of the podiatrists, so she didn't like that, so it wasn't a very good website. Then she called a couple, and they said, no, we can't get you in next week. Well, then she Googled something else, and I'm making this up, but like Foot Doctors America came up, and she plugged in her zip code, and what her problem was, and they said, you can see these, and they showed pictures, and she was like, I like that doctor's face. I'm gonna go to her, and but she was paying, and all of that is to say, so there are companies out there that will do that, and they will want to contract with individual physicians and with health systems, so that your picture can pop up. And have patients come to you via that way. The danger in that, though, is that oftentimes, they're going to, because for your ability to be on that web page, you're going to take a lower payment from them, and so that's how they're making their money. So if you make that sort of deal with the devil, you have to be very careful about that, because then that's always going to be a price point that's going to go lower and lower, and then it's going to interrupt your ability, whether you're a private practitioner who does a little bit of pro bono work, or whether you're a Catholic health system, if you do this, it's going to impact that ability. Sorry, that was kind of a long answer to a good question.
Answer. We're trying to make it a dialogue. Jeff, do you have a follow-on? Okay, great. Okay, let's see. I don't know anybody's name who's raising their hand. I think if I could ask you to ask your question.
Yeah.
And so I think of Catholic healthcare, I think of it in terms of image and identity. So when I think of identity, the internal sense of what we are, that goes back to what was articulated by Pope Francis. Or even Dan Solasi, or you go back to Rare Noir, dignity, common good, subsidiarity, solidarity, etc. Image is the external perception of what we are. And I have this sense that there's a lack of concordance for Catholic healthcare between image and identity. And there's papers that say that Catholic healthcare systems don't provide more charity care than anybody else. So how do we in Catholic healthcare distinguish ourselves, going back to the roots, the identity that we've described?
Well, you spoke to one of them. I don't know if I would accept that distinction. I mean, I think identity has both sides of that. Identity is how you're recognized by others. But I would say what's distinctive about us is going to be the integration of holistic care, so the spiritual care, the ethical care, the compassion, how we take care of the poor, how we actually reach out into the community, so that who is my neighbor, so that we're going in and inviting people into our hospitals and partnering with them out in the community in order to serve them. Those are some of the ways I would think of that image of Catholic healthcare, or those parts of Catholic identity that I would see. But I'm curious.
Do you think that's the public perception of Catholic healthcare in 2018?
Well, I think it probably depends on if you've seen one health system, you've seen one health system, they always say, and I think it really depends on the health system, and perhaps even in the particular community. So I would say yes. I'm new to SSM. I'm new to St. Louis, but I know very well where I came from. The people knew that they could come to St. Vincent's in Little Rock and receive care. When we had people who needed dialysis who were immigrants and didn't have any availability, they knew to come to our facilities. So I guess I'm sort of patting ourselves on the back a little bit. I'm the mission integration leader, so they should know, and if they don't, then ultimately it's partly my responsibility.
Yeah. Are you able to answer your own question? I think by asking, you've answered it maybe, but what do you think?
Yeah.
And I'm sensitive to this, but I've had a lot of people say to me, somewhat cynically, that Catholic healthcare is nothing other than occupying real estate in the healthcare market, indistinguishable from other entities. So I hear that as the image, and that bothers me.
Sure.
So that's why I'm challenging the question.
Great. Right here. Yeah, exactly. This young lady. Thank you.
Okay, I'm Denise Hess. I'm the director of the Supportive Care Coalition. And yeah, thank you. You guys are part of our coalition,
Yes.
and For those in the room, it's a coalition of Catholic healthcare systems dedicated to advancing excellence in palliative care. One of the struggles we have is increasing the understanding of what palliative care is out in the community. And so you've mentioned communities several times. I'd love to hear you, and not just with palliative care, but I'd love to hear your kind of dreams or hopes or aspirations about how Catholic healthcare could collaborate, coordinate with Catholic faith communities, specifically to address these social determinants. And like if you could write a blank check and just kind of make anything happen, what might it look like? Because I'm hoping to spark some ideas.
Yeah, that's a great question to get me dreaming here. Yeah, because I would say in my own past experience, I've had some success partnering with the Catholic faith community in developing programs and addressing the social determinants of health. The Child Advocacy Center that we started down in Garland County in Arkansas was one of those. I think churches in general, it's very similar. There are some churches and some dioceses and some communities where the church and the pastor are very open to this kind of partnership, and there are some that just because of the leadership within that church or within that diocese, they don't really see it as their issue. So, I mean, I think it's incumbent on us as parishioners, as members of the church, to push for that. I'm not coming up with a great answer, but I mean, it's something that's near and dear to my heart. That's why I was out there today. How do we partner with churches to improve our community?
Maybe another way to ask it is if you could say to maybe one of the more resistant clergy, you could make your case to them and say why they could benefit from partnering with Catholic healthcare. What would you say?
Yeah. Well, to improve the lives of the community that they're serving. I mean, I think that's what we're all about. A lot of times, I think, especially in large Catholic parishes with one priest, they feel like they're pretty limited in what they can do. And I'm sorry, I didn't mention palliative care. That's another distinctive feature right there. Catholic healthcare.
Are you able to answer your own question? Do you know? Do you have an idea?
Not yet.
Not there. Yeah.
But I think it is a key uniqueness from the Amazon J.P. Morgan Advocate Center.
Yes.
Berkshire Hathaway. They don't have faith communities around them that are the potential.
Yeah.
Yeah. This gentleman in the black, sitting next to Jeff Bishop.
Something that doubled down on the previous gentleman's comment. And I guess that's the fundamental question of, take a hypothetical small town in which there's two hospitals, a Catholic healthcare system and a secular one. And the nephrology group in town that contracts with both is made up of the exact same physicians, right? This is reality, I think, in a lot of towns in this country, in which a minority, if any, are actually Catholic. They go to both hospitals. In what meaningful way is the bedside interaction any different at Catholic hospital than at non-Catholic hospital? Because I think that's the distinction that this gentleman over here was getting at, is that if you go to these small Catholic practices that have sprung up in response to the lack of Catholicity of mega Catholic corporations, I guess the answer to his question is, how can you describe what the distinction is between that bedside interaction with random nephrology, this nephrologist who isn't Catholic, who goes between both hospitals? How at the bedside, how do you ensure that your physician's interactions with patients are, in fact, meaningfully different in a Catholic way?
Yeah, and I don't know. So you're saying that the nephrology group is owned by the Catholic facility?
No.
Oh, it's just independent
A doctor who goes to the Catholic hospital and maybe a non-Catholic.
Well, that makes it a much easier question. Yeah, then I couldn't say anything about that. I mean, and that's the history. I mean, for forever, physicians practiced in hospitals. The only really interaction with with the hospital administration was around the organized medical staff and, making sure quality and making sure you didn't have some quack and things like that. I mean, so there was no expectation that physicians had a better bedside manner or would practice in any way differently. So that, once they become, that's sort of the thing I struggle with. Once they put that cross out in front of their practice, so now they're not just nephrology associates, but they're SSM nephrology associates, then it's incumbent on me, not just me, but on other leadership to say, okay, now you've hung the sign out there. How do we change things if it's necessary to change it? They might all have great bedside manner. They might all treat ancillary staff perfectly. They may all take the poor, but those would be the things that we would have to work on. But
What do you sound pretty skeptical that could ever happen, right?
I think what you're basically saying is that there is a big difference between in the bedside interaction between your Catholic healthcare system and a non-Catholic healthcare system. I think that's the fundamental challenge.
well, the physician spends how much time with the patient every day?
I think most people would say, I'm a physician, so I'm going to go advise on this, but I anticipate that most patients look at their interactions with their physicians as the encounter they have with Catholic healthcare. So I guess that's my question, right? I mean, if you can't articulate the difference in what the actual interaction is with their healthcare provider for the Catholic hospital, I mean, it seems like at the end of the day, we run them shut down because there's nothing different.
I disagree with your premise that most patients would see the defining characteristics as based on the I don't know what kind of physician you are, the interaction with a physician who's there for 15 minutes when they're in the hospital for 24 hours.
Okay, so a minority of your nurses are Catholic, and a minority of your janitorial staff are Catholic, and a minority of all your other ancillary staff are Catholic. Again, the question applies. If there's nothing distinctive in those interactions, how in any meaningful way are you actually Catholic?
Yeah. That's a different question, because those people are our coworkers, our employees, and we set expectations for them around behavior, around compassion, helping them to understand the deeper purpose of their work, whether they're the environmental services work or the nurse or the radiology tech. So I would say that I'm not saying it's better, but we're making an effort to have distinctly different care.
This gentleman here in the short sleeve.
My name is Father Emmanuel. I've been involved in healthcare, both in Catholic hospitals and other hospitals, specifically Indiana University Health, for 12 years now. There's a clear difference between the two settings. Scientifically, they offer the same thing, but the approach and manner are totally different. Because Catholic healthcare sets some missions and values that they educate every employer, whether no matter how high you are or how low you are, they have the same training the same day from the inception on how to approach issues and how to approach patients and how to deal with different situations. And what patients take away it's not so much that they have the good health care or they have been made better, but how we treat them, what the differences are, and we speak to that at all times. So it's something that I have worked in 3 different hospitals, Strong Memorial in Rochester, Indiana University, and right now I am in Springfield. I'm the director of spiritual care. I'm involved in the training of doctors and nurses on how to relate with patients in a different way, apart from giving them medication.
That was a great closing statement, so thank you everyone for coming. If you'd like CME, please do find your way to the CME sign-in sheet, which right now is in the back of this room, but we're going to move it out there to the lobby momentarily. So we also encourage everyone here to sign up for our Bander Center email list and stay tuned for future events. Please join us in the fall. We're going to have ethnographer Harold Braswell, who's a St. Louis University faculty, is going to interview the economist Gerald Friedman about single-payer health. If you're interested in donating to our center, we would love to talk to you about that. If you'd like to become more involved in a different way, we would welcome that too. So I'd like to start out with a big thank you to the Conference on Medicine and Religion, to Jeff Bishop and Jeff Sokolov, and student Ben Parks for giving us this opportunity to present to this audience and for hosting us in this awesome space. So I'd also like to thank KETC Channel 9 for video recording and producing the video version of this event, to our staff, including Gunnar O'Brien, Denise Webb, and our medical student managers, Kelsey Rowe, Matt Gracka, Annie Sess-Kleifer, and David Starr, and to everyone who showed up and participated in the dialogue today. And of course, thank you to Patrick McCruden.